Hello everyone, Sangeeta here. Today let's have a revision on protein energy malnutrition. So malnutrition affects 1 in 3 people all over the world, which comes in different shapes and size. That means some may be too much malnutritious, like it may be affected with stunting, wasting, etc. Overnutrition even can cause obesity. Now the question from this topic is, what is PEM? Mention any 4 difference between Marasmus and Kwashiorkor. Sorry, a small mistake in the spelling of Marasmus. It is M-A-R-A-S-M-A-S. Protein energy malnutrition is mainly 2 types, Kwashiorkor and Marasmus. Kwashiorkor is mainly due to the insufficient protein intake. So there may be marginal energy here but insufficient protein intake. Whereas in Marasmus, there will be both deficiency of the protein and energy, insufficient protein and energy intake. So the meaning of Kwashiorkor is the disease that the first child gets when the new child comes. Naturally, we will give more attention to the second child, and additionally, in addition to that, if they are having poverty or some financial crisis, that time it may affect the health of the first child. That is the meaning of Kwashiorkor. And Marasmus, to waste away or dying away. So this table, which explains the WHO classification of malnutrition based on the percentage of body weight compared to the standard weight and the presence of edema and deficiency in weight for height. So according to that, it is classified into 5 types. Then it is Kwashiorkor, then Marasmic Kwashiorkor, Marasmus, Kwashiorkor, Marasmic Kwashiorkor, Marasmus, nutritional dwarfism and underweight child. Here gives the picture of a child with Kwashiorkor. You can see that the child is too much thin or lean, and he has a pot belly because of the edema. This is a presentation of child with Marasmus. You can see that the child is too weak. He does not have any energy to withstand, and if the treatment is not taken properly on time, child may die. So the biochemical features of protein energy malnutrition. What all the metabolic profiles will be getting affected? Metabolic rate is decreased because there is no energy at all. So metabolic rate is decreased. Then hypoalbuminemia. Especially in Kwashiorkor, there will be edema because of the hypoalbuminemia. Usually the albumin level will be less than 2 gram per deciliter. The normal level of serum albumin is 2.5 to 3.5 gram per deciliter. So that is the biochemical marker of Kwashiorkor, where there will be protein level or albumin level will be less than 2 gram per deciliter. RBP, that is retinol binding protein level, will be too much low. Then immunoglobulin IgG, that is immunoglobulin G, increases due to associated infections. Fatty liver can be associated in Kwashiorkor but not in Marasmus. It can be due to decreased lipoprotein synthesis, because in Kwashiorkor it is mainly due to protein deficiency. So there will be decreased lipoprotein synthesis and decreased availability of LDL. Because of that, the child may get fatty liver. And where there will be increase in serum free fatty acid, and glucose tolerance can be normal. Hypoglycemia may be seen in marasmic child but may not be in Kwashiorkor child. Hypokalemia and dehydration. Hypokalemia means decrease in potassium level in blood, and dehydration may be seen if there is associated diarrhea in case of protein energy malnutritious children. Then hypomagnesemia, decreased level of serum magnesium can be associated. Then total body water content increases in Kwashiorkor up to 60% of body weight because of the edema, but not seen in marasmic child. So this is all about PEM. Now the second question was difference between the Kwashiorkor and Marasmus. They were asked you to write any 4, but it is better you to study all these points in thorough. So while you are comparing these two, you can make 3 columns. the points and make one column for Marasmus and one column for Kwashiorkor. So the age of onset for Marasmus is less than 1 year, whereas Kwashiorkor after weaning period only, that is after first year of age, 1 to 5 years, that is our age of onset. Then deficiency. In Marasmus, both the calorie and protein, and in Kwashiorkor only protein. Then cause of marasmus is early weaning and repeated infections can be the cause for marasmus, whereas Kwashiorkor, starchy diet after weaning, precipitated by acute infection. Then growth retardation. There will be marked growth retardation in marasmic child, but the growth retardation may be present in Kwashiorkor child. Then attitude. The child may be very much irritable and fretful in case of marasmus, and lethargic and apathetic appearance in Kwashiorkor child. Appearance. The child may be shrunken with the skin and bones only, and he may be or she may be very much dehydrated in case of marasmic children. Whereas in Kwashiorkor, he looks plump due to edema on face. He may be appearing very chubby, but it is not due to the proper weight or any nutrition. It may be due to hypoalbuminemia that leads to edema. So child may looks plump due to edema on face, and lower limbs also shows edema. Then appetite. In marasmic children, the appetite may be normal, but in Kwashiorkor children, the appetite, there may be anorexia. Anorexia means lack of appetite. That is anorexia. Another points are skin. In marasmic child, the skin may be very much dry and atrophic, whereas Kwashiorkor, grassy pavement dermatitis due to peeling, cracking and denudation. Note the point, there may be associated dermatitis occurs in Kwashiorkor. In hair, regarding the hair, marasmic children, no characteristic change in hair of marasmic child, whereas in Kwashiorkor child, sparse, soft and thin hair curls may be lost. Other associated features like other nutritional deficiencies, watery diarrhea, muscles are weak and atrophic in case of marasmic child. In Kwashiorkor, angular stomatitis and chelosis are common. Watery diarrhea may be there. Muscles undergo wasting, crawling and walking are delayed. Then serum albumin, marasmic child 2 to 3 gram per deciliter. Whereas in Kwashiorkor there will be severe hypoalbuminemia less than 2 gram per deciliter. And serum cortisol will be very much elevated in case of marasmic child and decreased in case of Kwashiorkor child. Regarding the treatment of PEM, optical response is observed with diets providing 150 to 200 kilocalorie per kilogram body weight. That means calories should be given along with protein, that is for that protein 3 to 4 gram per kilogram body weight should be given. So a mixture of 3 parts of vegetables protein, specifically Bengal grams and peanuts, and 1 part of milk protein is very much effective in case of PM. Then malnourished children tolerates fat very well and may form a major source of calories in the diet up to 30%. So it should be supplied with the fat also for the case of PM. Then monitored by disappearance of edema and rise in serum albumin level and gain in weight. So that is a therapeutic monitoring, how to identify that the child is getting better. So we can estimate the level of serum albumin, even we can monitor the weight gain. Sequelae of PM. Severe malnutrition in early life can lead to permanent and irreversible physical and functional deficit. So there will be changes in mental function and intellectual potential due to the malnutrition. So remember, if it is not corrected on time, it may affect the brain function. Then severe persistent malnutrition can have deleterious effect on the intellectual capacity even in later in life. Moderate and mild forms of PM may not have any sequelae if corrected on time. That's it. This is all about protein energy malnutrition. All of you please read the quote. We can be the generation that stops children dying of hunger if we also contribute. Thank you.